Welcome everybody to our webinar today. This is a webinar specifically for the chiropractic industry. It is the 2019 Chiropractic Update and Coding Guidance webinar. And I felt very compelled to put this webinar together because of so many changes that are taking place within the chiropractic profession. And so we're getting a lot of questions from our clients about why certain claims are not getting paid the way they used to get paid. We are seeing changes in reimbursements, some for the good, some for not so good, and certainly we are seeing some significant changes in the documentation burden that is being placed on the chiropractors and, frankly, the medical professional over the United States. And so what we're going to do today is we're going to talk about how some of these changes are affecting the chiropractic profession, what we can do to streamline some of these processes, answer any particular questions that you all may have about what's going on, and hopefully by the end of the session today, most of your questions will have been answered. So let's go ahead and get started. So the main things we're going to talk about today, what's new, are, number one, we'll talk about a couple of the ICD-10 coding changes that have affected the chiropractic profession. There's not very many this year, but there are some that are significant enough that if we don't make the changes to our processes, we will see a lot of claim denials. The other thing that I want to talk to you about is a major proposed change to the way evaluation and management services are going to be reimbursed and the documentation requirements for E&M services starting in 2019. The other thing that we'll spend quite a bit of time on today are the developments and changes in the commercial payer medical policies for payment and reimbursement of chiropractic and physical medicine services. So it's going to be super important for us to have a really good handle on this, not just the providers, but the billers and the billing reps and the billing assistants within Gold Star Medical. I have invited both our clients and their billers and their billing team to this meeting, so hopefully everybody is on and everybody will get the same information. I also want to let you know that this webinar is being recorded, so if at any time you need to go and see a patient or you start seeing patients in the next hour and you can't stay on for the entire webinar, then absolutely we will have this webinar recorded. I'm just making sure that everybody is on mute. Yes, they are right now. From time to time, I may have to open up the controls and make sure. We want to have a really good recording of this, so we're going to keep everybody on mute until the end when we get to the Q&A. So let's go ahead and get started. The first thing, again, we're going to talk about are the changes and deletions to the ICD-10 code book. Now, of course, the ICD-10 code book, we know starting in 2015, went from about 13,000 codes to about 63,000 codes in 2015. And as you can see by the slide up here, in 2018, the code book had already expanded to 71,000 codes. And from there, in 2019, it will expand a little bit more to 71,932 codes. So all told, this year was a fairly quiet year for ICD-10 changes. There were 279 additions to the code book, 51 deletions, and 143 revisions. Now, what a revision is typically the code itself doesn't change, but the text and the description of the code will change slightly. And sometimes it's as simple as a grammatical error that was present in the original code set that they have found and they're revising the code. So they call that, even if they change a comma or a space in the code book, then they're going to call that a code revision. And so we're not we're not too terribly concerned about code revisions, but we certainly want to make sure that that we understand any new codes that are coming into play that we would need to know about in the chiropractic profession. So from what I have found and what I have seen, the main code, there have been some revisions to the M50 codes, which are your cervical disc disorder, cervical disc displacement, and cervical disc degeneration codes. But these are simply text revisions, and so there were additional spaces that shouldn't have been there. There was a comma that was missing or that was added. So really there is no measurable change to the description of those codes. But there was one key deletion that we do need to be aware of, and that is the code M79.1, the code for myalgia. This is a very, very popular code with chiropractors, and so the code M79.1, as of October 1st of this month, was deleted from the ICD-10 code book. And what that means is that from any date of service after October 1st, if you use that code and you bill with that code, your code is the claim is going to be rejected. Normally it will get rejected at the clearinghouse if you have not updated your software. Some software programs will reject it in the claim scrubbing process if you have the most recent updates to your software. But most of the time where we're going to see these claims rejections are going to be in the at the clearinghouse level. So once your biller bills out the claims, those claims are going to get stopped at the clearinghouse, and then they're going to have to get fixed and changed. And see, I have somebody who is not on mute, so okay, here we go. I'm going to go ahead and mute. If you do come on, please make sure you mute yourself, if at all possible. I'll try to keep everybody muted as they begin to come on this presentation. So with that said, what we have to do with this M79.1 code is, number one, delete it from your EMR and practice management database. Don't even give yourself the opportunity to use that code. So billers, make sure that this is not in the ICD-10 code set for your practice management software, and make sure that the codes that are replacing the M79.1 have been added. And those codes that have been added are the M79.10, M79.11.12, and also the M79.18. Also, if you are on this webinar, and please make sure you put yourself on mute so we don't have any interesting sounds coming in. Okay, we still have more people coming on. I'm trying to get everybody muted. For the chiropractors, most of the doctors who have asked me about this code have asked me which of these four codes would I replace with the M79.1. For most of you, unless you are coding for myalgia of the mastication muscles or of auxiliary muscles of the head and neck, you would typically replace the M79.1 with the M79.18 code. That would be the most specific for general myalgia on a patient. So be aware of that. Really, that is the main code change that it has affected the chiropractic profession in a fairly measurable way, because that is a fairly popular code with chiropractors. So now the next thing that I want to talk to you about is the big changes that are being proposed to evaluation and management services at CMS right now. So on July 12th, let me give you a little bit of a back history on this. The CMS released its proposed changes for the Medicare physician fee schedule for 2019. These proposed changes were published in the Federal Register on July 28th with a comment period which closed on September 10th. The anticipated change from a proposed rule to a final rule is supposed to take place sometime after November 1st and before December 31st. So the chatter that we are hearing is that these proposed changes are going to take place as of January 1st, 2019. But at this point, I have to disclose to you that they are, at this time, only proposed changes. However, if the change moves from a proposed rule to a final rule anytime between November 1st and December 31st, this is going to create significant revisions to coding and documentation of office visit E&M services. And these are going to, for this year, for 2019, are going to apply to the new patient, outpatient office visit services, and the established patient outpatient office visit services, which are codes 99201 through 99205 for new patients, 99211 through 99215 for new patients. And so here is, let's just talk a little bit about E&M. Now, E&M stands for Evaluation and Management. We also, in the chiropractic profession, we refer to these types of codes as exam codes or office visit codes. And in the past, up until now, and then moving forward into 2019, to the end of 2018, the choice of E&M codes is based on something called the 1995 or the 1997 E&M coding guidelines, of which to choose the correct level of code, you have to document 3 key components, and then there are 4 contributory factors that can also be documented. The 3 key components under the current system are your history, your examination, and your medical decision-making. And then underneath the history, there are 3 elements which comprise of the HPI, which stands for History of Present Illness, and that's essentially your consultation in the chiropractic, in Chiro world. We're looking at the consultation. We're talking to the patient about what's going on with them, what kind of pain do they have, what makes it better, what makes it worse, what are the modifying factors, is it better when you're sitting, standing, lying down, what have you done for that pain? That's all part of your HPI. Now, the HPI, under the guidelines, the current guidelines, must be recorded by the provider. The ancillary staff can do that, but the provider has to go in behind the ancillary staff and re-record that and make sure that they are attesting to all of that information. So the ancillary staff cannot record HPI under the current guidelines. The review of systems may be recorded by the ancillary staff, and the past family and social history can be recorded by the ancillary staff. However, the provider must record the HPI. And then, of course, we have the exam, and the level of exam and the extent of the exam factors into the choice of the E&M code, as well as medical decision-making. We also have 4 contributory factors, which are counseling, and in the chiropractic world, that's our report of findings, coordination of care, nature of the presenting problem, and time. And under the current coding criteria, time can be used as a key component when the time spent in counseling and or coordination of care dominates more than 50% of the encounter. That is the current E&M coding criteria. Now, under the new changes, there are 5 key aspects of the proposed changes to the E&M coding, and the first one of them is regarding time. Under the proposed changes, physicians may select the level of service based on time as a key component, or by using medical decision-making alone, regardless of the level of history or physical exam performed. Currently, selecting a visit based on time requires you to document the duration of the face-to-face time with the patient, provider face-to-face time. So it's not the total amount of time that the patient has spent in the office, but the face-to-face time with the provider, and that it is greater than 50% of the visit must be spent in counseling or coordination of care. The proposed changes would eliminate the second requirement, simply allowing physicians to select a code based on the total length of the visit, even if counseling doesn't dominate the service time. So for those of us in the chiropractic profession, that's kind of good news. I mean, that eliminates a lot of requirement that we currently are under in order for us to be able to code a level 2 or a level 3. Now, it's good news, but as you will see in these other aspects of the proposed changes, it's not really going to make that much difference. So the other key aspect is going to be that medical decision making is being looked at as the driving factor for the code selection. And so again, I'm going to just go through my list of attendees here and make sure everybody is on mute. Mute other people. Okay. So especially for new patient visits, which now currently require meeting requirements for all 3 components of history, exam, and MDM, satisfying requirements for higher levels of service can be difficult. Medicare is proposing to allow physicians to select their level of service for both new and established patients using only the MDM component, and the requirements for that would remain the same as they are now. And so if you do any type of E&M auditing, there is a complete worksheet that you can use to determine your level of MDM. And if you ever want to see that, or if you've never used it, please let me know, and I'd be happy to get that to you. So that is the second of the key aspects. The other thing that Medicare is wanting to do is reducing unnecessary requirements. So Medicare is proposing to no longer require physicians to re-record information regarding the chief complaint and HPI previously documented by ancillary staff. So if you remember what I said earlier, in the current guidelines, the provider has to record or re-record HPI. You won't have to do that under the new paperwork reduction initiatives that are taking place with E&M coding. You can simply verify rather than re-enter the chief complaint and patient history when captured by ancillary staff. And in order for you to document any E&M code, the minimum requirement is currently going to be associated with what we now look at as a level 2 visit, or a 99202 or a 99212. That sounds great, but the reason why this proposed change is taking place, and plus it also is going to allow different specialties such as chiropractic to choose to document factors that are more relevant to your clinical practice, which is also great. But what is happening is they are looking at taking all of the E&M codes and creating a single payment rate. So it's not going to really matter which code you choose in 2019. You can choose a 99202 or a 99205, and you would get paid at approximately the same rate. Same thing with established patients. So let's take a look at what the Medicare fee schedule currently looks like. And now what we're looking at is we're looking at national rates. Of course, current localities, these rates may be higher, they may be lower than the national rate. But if you can see the current non-facility, which is a doctor's office, payment rate for a 99203 is right now nationally around $110. The proposed payment rate is going up significantly for a 99203 to about $135. Now, most chiropractors, chiropractic new patient services and new patient visits, at the very most, unless you're doing like a personal injury exam where you're really doing an extensive neuro-orthopedic testing, most chiropractors are qualifying. When I'm doing, chart audits for new patient visits, most of you are qualifying at a level 2, or most of you are level 2, and some of you are level 3 visits. And so you can see that currently your reimbursements, Medicare reimbursements, would be around $76 for a level 2, $110 for a level 3. The proposed payment rate is going up to $135 regardless. Now, this is going to be really good for some providers and really bad for others. For those providers who routinely do very high-level E&M services like neurologists and so on and so forth, that $135 is going to represent a significant pay cut for those who are coding, consistently at a level 4 or a level 5 rate. Same thing with the established patient exams. So the current rates for level 2 established patient exams around $45. Medicare is looking at bumping that up to $93 a visit on the national level. And again, the local rates may change slightly, but they are going to be a fixed rate regardless of the code if this proposed rule goes through, which we anticipate that it will. The fifth key aspect of the E&M coding changes is a primary care and specialist payment bump. What that means is that there will be add-on codes for primary care doctors and for 10 different specialties that report high percentage of evaluation and management services and that typically do a higher level of code. There will be add-on codes that they can use in addition to the 99, the E&M code to receive additional reimbursement. Primary care doctors, their add-on code will give them about a $5.41 on the national average bump. The specialists will see about a $13.70 per visit bump. Now, chiropractors are not included because we know that, I know I'm talking about Medicare, and let me come back to here first, but, I know I'm talking about Medicare, and probably some of you are scratching your head thinking, well, Medicare doesn't even cover exams for chiropractic, and I will get to that. But it's going to be important for us to know what's going on, because as Medicare goes, we know that so will the commercial payers. And so it's important to know what's happening with Medicare so we can anticipate what may be taking place with commercial payers next year as well. One of the things that Medicare is also proposing in their rule, which is not good for chiropractic, not good for physical medicine, is going to be a provision for a 50% reduction for multiple procedures performed on the same day as evaluation and management services. And you can see that the procedures that are listed, obviously spinal manipulations are not in this list because spinal manipulations are considered a primary procedure for chiropractic. But for multiple procedures, physical therapy procedures, when performed on the same day as an evaluation and management service, the Medicare is going to look at a 50% reduction on those physical medicine procedures. And this is the list that Medicare has provided that is targeted for this 50% reduction. And so you can look at this list, and of course you have your handouts. Hopefully you were able to copy those handouts, but you will also be able to find this list. I have a source document for you at the bottom of this slide that is also on your handouts, and you can go there and get a copy of this list in an Excel format. And so these are on the list for the 50% reduction. And again, remember, as Medicare goes, so may commercial payers go. So the commercial payers are looking very closely at these proposed reductions when multiple therapies are being performed in conjunction with evaluation and management services. So what is the impact to physicians? These modifications, if finalized, number one, would only apply to office visit codes and only for Medicare, at least in 2019. Now, we don't know if commercial payers will begin to immediately follow suit, or it'll take a year, or it'll take a few months for commercial payers to start following the same guidelines as Medicare, but usually it's pretty quick. And so as a result, the existing 1995, this is what Medicare is saying, the modifications are only applying to Medicare, and as a result, the existing guidelines will continue to apply for other services such as hospital visits and for commercial payers. Now, commercial payers will have the latitude to adopt these guidelines as quickly as they want to, and some of them may do so very soon after this rule becomes a final rule. So billers, if you're listening to this, you need to keep your ear to the ground for any impact that commercial payers may be developing as a result of these E&M changes, because we do know that you know, office visits and exams are paid for by many of the commercial payers, although we are seeing some impact to that as well, and we'll talk about that in just a little bit. Although Medicare right now is only proposing changes to the 99201 through 99215 codes for 2019, at this time the agency, meaning CMS, indicates that it does intend to use a stepwise approach and expand the finalized policy to other E&M code categories in coming years. And so eventually what it's looking at is all E&M services becoming subject to this type of a flat rate payment system. So what is the impact to chiropractic? Right now, Medicare currently does not cover codes 99201 through 99215 or any of the therapy codes that are scheduled for the multiple payment reduction when performed, supervised, or ordered by a DC. However, I have to caution you, it is anticipated that commercial payers will quickly fall in line with these proposed changes once the changes are finalized by CMS. Doctors of chiropractic and their billers will need to keep a close ear to the ground with respect to changes that may be taking place with the commercial payers' payment policies, which is going to lead me to the next section of our webinar, which is going to be what in the world is going on with commercial payment policies. All right. This is where we're going to spend the majority of our time, and this is where I know we're going to have a lot of questions. But what I want to kind of give you is sort of some background on how commercial payers establish payment policies for reimbursement of chiropractic services and any medical services for that matter. So the first thing a commercial payer does, and when we're talking about commercial payers, we're talking about Blue Cross Blue Shield, United Healthcare, Aetna, Cigna, so on and so forth. Most of the time, a commercial payer is going to closely follow coding guidance, reimbursement, and payment rules based on CMS's, which is Center for Medicare and Medicaid Services, national coverage determination policies for different types of medical procedures, medical services, and certain kind of procedure codes. Also, CMS's Medicare Administrative Contractors local coverage determination policies. The national coverage determination policies are called NCDs. The local coverage determination policies are called LCDs. And so, for example, with chiropractic, every Medicare payer, so for example, if you're listening to this and you're in California, we submit claims to Noridian. If you're in Texas, we submit claims through Novitas, and so on and so forth. So there are different Medicare administrative contractors in which Medicare claims are submitted depending on what state you practice in. And those Medicare administrative contractors can take the national coverage determination documents for chiropractic services and expound on that and create LCDs, which are local coverage determination documents. And we're not going to have time in this particular webinar to go over Medicare LCDs, although they are very, very important in the chiropractic profession to make sure that you are billing Medicare correctly based on the LCD that your Medicare administrative contractor puts out. And so you have to make sure that, number one, for those of you who are billers, make sure that each one of your clients has access and a complete understanding of the LCD for their Medicare carrier if they are billing Medicare, you know, with their patients, which they should be. And providers make sure that you have access to those LCDs, because those LCDs are going to help you determine what your approved diagnosis codes are for the spinal manipulation codes, what your documentation requirements are, and even what utilization guidelines you have. And some of the Medicare administrative contractors have very specific utilization guidelines. For example, Novitas in Texas, and they also handle New Mexico, Colorado, some of the eastern, northeastern cities, sorry, not cities, but states, Oklahoma, go through Novitas. Novitas says that a patient may have up to 12 chiropractic visits per month, no more than 30 per year. And so other LCDs are not that specific. And they also, some of the LCDs give you diagnosis codes based on if you use these diagnosis codes secondary to the primary diagnosis, you can expect to be approved for short-term treatment of that patient, or medium-term treatment, or long-term treatment. And some of the LCDs are very specific, and they will actually say what that represents. What does short-term treatment mean? And some LCDs will tell you 12 visits are short-term treatment. But the bottom line is you need to know what your LCDs are telling you. And if you, as one of my Gold Star clients, feel like you need additional training on how to read and interpret your LCDs, get with your biller, and we'll schedule a separate little webinar for you to go over that as part of your service with Gold Star Medical. The other thing that commercial payers will look at, and so commercial payers look at these NCDs and they look at these LCDs, and many of their coding, reimbursement, and payment rules are based on what these LCDs and NCDs are telling you. The other thing that commercial payers look at, as well as Medicare, are the National Correct Coding Initiative policies and edits. And these are very, very important edits that will take codes that are paired together, and based on the pairing of these codes will help determine whether these codes can be reported together, never reported together, or reported together with certain modifiers. And using these foundational policies and guidelines, commercial payers will then develop medical and reimbursement policy guidelines specific to that commercial payer. Now, commercial payers have great latitude in the interpretation and use of the national policies. Unless they have Medicare Advantage products, then they have to follow much more strictly Medicare guidelines. And these commercial payer national policies or the commercial payer local policies may override the national policies with what they call corporate, which are specialty-specific edits, or local, which are state-specific edits. And then finally, a patient's policy may dictate services that are paid or not. So we have a lot of moving parts when it comes to how commercial payers reimburse chiropractors in the chiropractic profession. So what I'm going to do here is, now obviously we represent clients all over the United States, from coast to coast, okay? And so we probably right now, Gold Star Medical represents about 35 states. And so there's no way in this short webinar that I can go through every single commercial payer's corporate or local policy, but what I'm going to do is I'm going to show you an example of one that is actually very, very well written. It's very, very easy to read. And so what you're going to need to do is, this is going to give you some insight into what is going on at the corporate local level of Blue Cross Blue Shield in general. And of course, it's not just Blue Cross Blue Shield. Aetna, United Healthcare has medical policy guidelines for chiropractic care that you must be aware of and know for your particular state. And if it is a national overarching policy that United Healthcare has, like for example, United Healthcare has a policy that is indigenous to all United Healthcare plans throughout the United States, you would need to gather up that national policy and have a good understanding of it. But we're going to use Blue Cross Blue Shield of Kansas as an example of what a corporate or local edit would look like for you as an in-network provider with Blue Cross Blue Shield. And while this is the Kansas policy, I will tell you that in looking at other states' policies, they are written very, very similarly, if not exactly like this, okay? And so Blue Cross Blue Shield doesn't reinvent the wheel. They are taking these local edits and these local policies, and they are incorporating them into each of the different state plans. So this is an excerpt from Blue Cross Blue Shield medical policy on evaluation and management procedures. It says here, as stated previously, and this is part of the earlier part of the BCBS Kansas policy, expects specific criteria identified for each code to be met and documented in the medical record when using a particular level of CMT code. So in other words, they are saying that the CMT that is being reported on the claim has to be substantiated by the medical record. Now, in talking about evaluation and management services or exams, they are saying, Blue Cross Blue Shield of Kansas says, as a new patient, you can bill a new patient E&M procedure and a CMT, which is a chiropractic manipulative therapy procedure, on the same day. So Kansas allows that. Some other states, now their corporate policies are not allowing that. For example, Blue Cross Blue Shield of Illinois, they have some very, very interesting wording that is making it to where in some cases you cannot bill any type of an evaluation and management procedure in conjunction with the CMT procedure on the same day. Blue Cross Blue Shield of Kansas is saying that an evaluation and management procedure for an established patient will be considered content of service of the manipulation. And they're saying reevaluations will also be considered content of service. And what they're saying categorically is that based on this local edit, they're not going to pay for a reeval if the reeval is being done on the same day as a manipulation. And the majority of Blue Cross Blue Shield plans are taking this local policy and creating that into the chiropractic policy. Some of the other things that we are seeing as part of the corporate policies for Blue Cross Blue Shield are the policies for multiple therapies. And so you have to read your policies very carefully. If you do multiple modalities in your practice, you need, and you're wondering, well, how come I'm not getting paid for all of these modalities? Or how come I'm getting paid for one and not for another? So, for example, this corporate policy states if eSTEM 97014, eSTEM attended and ultrasound are provided to the same area at the same session, you're going to have to attach medical records. If medical records are not attached, only 97032 will be allowed. So the other two will get denied, ultrasound and unattended eSTEM, and attended eSTEM will get paid. Okay, so that is written into that corporate policy. And again, your Blue Cross Blue Shield policies have similar wording that you need to know about. Multiple units of physical medicine modalities. These guidelines that Blue Cross Blue Shield of Kansas has involve more than 4 modalities per date of service. Or the guideline involves the daily unit being exceeded. It says these guidelines involve more than 4 physical medicine modalities and or procedures being billed on one date of service. So what Blue Cross Blue Shield of Kansas says, if you do a spinal manipulation and 4 therapies, let's say you do a spinal manipulation, eSTEM, and 2 units of rehab, that's 4 modalities, right? If you do any more of that, then those additional modalities will be denied and will be you will have to write those off. So these are what some of the wording is we're seeing in these Blue Cross policies. Traction, mechanical traction. This policy states that this code is 1 or more areas, so it's limited to 1 regardless of the time spent, but it's also very specific in saying that rollerbed is not considered mechanical traction and is not medically necessary. So if you're putting your patients on a rollerbed and billing mechanical traction, and then you get audited and your documentation states, patients placed on roller bed for 10 minutes, that claim is going to get retrospectively denied, and that money is going to get taken back. So you need to understand what constitutes mechanical traction, and roller bed is not it. E-stim, okay? Some of the things that it talks about, E-stim in the Kansas policy under unattended is the billing of electrodes. And I know that you know, there have been in the past management organizations and other billing organizations, coding organizations that tell you, oh, bill for everything, you know, bill for the electrodes, you'll get paid extra money. But the medical policies are becoming very clear now in that the electrodes and other supplies that are being used to administer any modality are considered content of service, and the modality and should not be billed separately. And that, you know, that is actually crossing over into medicine and surgical procedures and surgical supplies and so on and so forth. Very, very difficult to unbundle those supplies from the procedure and get paid for them. You know, these are just, again, attended E-stim. They're saying 15 minutes is 1 unit of service, and one of the things that the medical policy is stating is that this code is for 1 or more areas, so the unit of service is limited to 1. It doesn't matter if you do 30 minutes of E-stim, you cannot bill 2 units, even though it is a timed code. And so you have to be aware of that. Neuromuscular reeducation, they're very, you know, Blue Cross Blue Shield of Kansas and most Blue Cross Blue Shield corporate policies for chiropractic services is stating very clearly that 97112 is not appropriate for acute musculoskeletal problems and should not be used for spine or extremity stabilization. And it's putting you on notice. It says, note, 97112 is monitored for overutilization and misuse. So what that means is if you are routinely coding 97112, depending on the diagnosis codes that you're attaching to that neuromuscular reeducation code, you could be at a great audit risk. And Blue Cross Blue Shield of Kansas is definitely, and other Blue Cross policy plans throughout the United States are looking at 97112 very carefully. The corporate policy for massage for Kansas is very clear. It says 97124 will deny content of service, meaning that Blue Cross Blue Shield of Kansas does not cover massage therapy, even if it says it's covered under a patient's policy. Blue Cross Blue Shield of Kansas does not cover massage therapy. And here's the big one. This is the one that many chiropractors have problems with. Many chiropractors code the 97140, which is manual therapy technique, which consists of myofascial release, manual traction, joint mobilization, manual lymphatic drainage. Those are all within the description of 97140. It states very clearly in the Kansas policy, and I'm seeing this in other state policies as well, 97140 will deny content to the manipulation. What that means is that when 97140 is billed with a manipulation, regardless of the modifier, it's going to deny unless, and if you want it to get paid, it does give you a statement here that says it may be medically justified with appropriate documentation. So what does this mean for you? It means that payment may be considered if claim is submitted with doctor's notes every single time. So if you bill the 98940, 98941, and 97140, even with the modifier, even if you pinpoint the diagnosis codes correctly on the claim, this corporate policy is, and that it is now overarching most Blue Cross Blue Shield plans throughout the United States, is denying the 59 modifier unless notes are sent with the claim. And I was actually at a medical convention a couple of weeks ago teaching an update class to a bunch of medical professionals, not chiropractic, and they were lamenting this because they use the 59 modifier on many, many different medical procedures. For us, it's the 97140, the 97112, and the 97124 that we typically use that 59 modifier on. But other medical specialties use this modifier extensively. And Blue Cross Blue Shield is denying categorically throughout the medical profession this 59 modifier, and most of the billers are just having to drop these claims to paper and send notes or electronically submit the claims with notes electronically. It's a huge mess right now, but Blue Cross Blue Shield at this point is winning the war, okay? There is a lot of pushback. I know from the American Chiropractic Association. I know state associations are pushing back on this very hard. I know that the American Medical Association is pushing back on this very hard. But right now, as things stand, if you're seeing categorical denials of 97140 and 98940 or 98941, the only recourse you're going to have is to resubmit with doctor's notes. But beware, doctors, okay? Because, and I'm not saying that our clients are guilty of this, you know, but we, as a chiropractic profession in general, are horrible at documentation, okay? And so if you're going to submit notes for 97140, you better make sure that the notes are going to justify that 59 modifier. So what does CMS define that 59 modifier to be? And that is a distinct procedural service under certain circumstances, and this comes directly from CMS. It may be necessary to indicate that a procedure or service was distinct or independent from other non-E&M services, which is a medical procedure, that's not an exam, performed on the same day. Modifier 59 is used to identify procedures, services other than E&M services that are not normally reported together but are appropriate under the circumstances. Documentation must support a different session, different procedure or surgery, different site or organ system, separate incision, excision, separate lesion, separate injury or area of injury, not ordinarily encountered or performed on the same day by the same individual. Okay, so what does that mean to you? That means that before you ask your biller to start sending doctor's notes, we have got to make sure that your notes are going to allow those services to get paid and not just be a colossal waste of time for everybody, or worse yet, kick you up to an audit risk. And so, you know, I know that some of you that are on this call are Gold Star clients. I mean, some of you use myself to do your chart audits, and and I will help you look at your documentation if you need me to. Some of you on here are KMC clients. My friends at KMC University are experts at this, and so you know, if you are a KMC client or you want to do a really, really deep dive into your documentation, you may want to get with Kathy Mills-Chang or one of the consultants over at KMC and have them do an extensive chart audit for you. I mean, I'm more than happy to do that. I have, we've got, MCSPs who have the qualifications to do chart audits, but if you're already with KMC or you're thinking about going with KMC to really take a hard look at your documentation procedures, go ahead and do that because this isn't going away, all right? Your documentation requirements are not going to lessen, they are going to increase in order for you to get paid for these multiple therapy units and in order for you to get paid for your exams and your manipulations or procedures on the same day, or in order to get paid for your manipulation and your myofascial work on the same day. Make sure that your documentation will support those services being submitted for additional scrutiny. I have to give you a good warning on that. Some of the other things that we are finding that is being problematic with our providers are our providers who are using or utilizing services that are considered experimental or investigational, and making sure that you know correctly how to bill for them and how to notify your patients about procedures that may be considered experimental or investigational, to avoid you having to contractually write these off when you bill them. Many payers nowadays have their own version of an ABN form, and for those of you who bill Medicare, an ABN stands for Advanced Beneficiary Notice. And in the past, it was usually sufficient to be able to take your financial policy and have a statement in your financial policy that says, I understand that services not covered by my insurance or my plan, or services that are experimental or investigational, would be my financial responsibility, and you have the patient sign that, and that's fine. But if you have a contract with Blue Cross Blue Shield or with United Healthcare or Aetna, and within their clinical policy guidelines, there is a statement saying you have to use their form, and if you don't, you have to write off the services. And so, for example, here with Blue Cross Blue Shield of Kansas, they have a form called a limited patient waiver. And it states very clearly under the experimental investigational procedure section, these procedures are considered experimental and are a provider write-off unless a limited patient waiver is signed before performance of the service. And then it tells you that you have to use modifier GA to demonstrate the waiver, that the waiver is on file, okay? So billers, you need to know this, because if your providers are billing for any of these experimental services, you need to know how to handle the billing of it, making sure that there's a GA modifier if this is what the payer is telling you to do. And doctors and front desk staff, office managers, you need to make sure that you have all of these payer-specific waivers on hand to use in the event you are billing for experimental procedures. And the experimental procedures under the medical policy guidelines are telling you that you have to have the patient sign this type of a waiver. This is an example of the limited patient waiver for Blue Cross Blue Shield of Kansas. I've seen this particular form adopted by many other Blue Cross plans. And so make sure you've got these waivers on file. So if the medical policy refers to their version of an ABN, your own internal document like a clinic financial policy will not suffice. And if it gives you a CO denial, meaning contractual obligation, that means you're going to have to write that off. Follow the commercial payers' medical policy guidelines for correct modifier use, if applicable, and make sure that your front desk, CA, or person who handles the financial consult has copies of these commercial payer ABNs handy for the patient to sign. So what are some of the experimental procedures that Blue Cross Blue Shield usually looks at? Surface EMG, so your SEMG codes, like your your MyoVision codes. These are considered experimental and investigational. Low-level laser therapy, considered experimental and investigational, S8948. Now, interestingly enough, Blue Cross Blue Shield of Kansas actually does not consider S9090, which is axial decompression therapy, to be experimental or investigational, but Blue Cross Blue Shield of Texas does. And so you have to, again, you have to go back to your state your state Blue Cross policy to see which services, if you perform any of these, are considered to be experimental investigational, and make sure you're using the right kind of ABN forms for them. The S9090 code in Kansas is not considered experimental, but what that means is that there is a fee schedule attached to it. So if you're charging, you know, $100 per service, per session for the S9090, there may be a separate medical policy on S9090 on the for example, the S9090 in Kansas, and I haven't looked this up, but I would imagine that there is one, might limit you to 12 visits per year or 12 visits per diagnosis. And so you would also have to abide by the fee schedule that they submit for that S9090 code. Now, if it's experimental and investigational, you don't have to follow a fee schedule, but you do have to follow the rules for the waiver of liability. So just be aware of all of that. Sometimes providers will ask me or ask a biller about a code for a service that is not routinely associated with chiropractic. Okay, kinesiotaping is one of those codes, and there are specific codes for kinesiotaping that are in the 29,000 series. I can't remember exactly what those codes are. The problem with those kinesiotaping codes is that they are found in the surgery section of the CPT code book, which means that most payers look at these as surgical procedures, which are not within the scope of practice of a chiropractor, but we do kinesiotaping. So the question is then, what code should we be using? And you need to check your commercial payer medical policy for guidance on this. Blue Cross Blue Shield of Kansas says that this service should be coded as 97039. Send notes with the claim and make sure you have the patient sign a limited patient waiver, because it is considered experimental investigational under the chiropractic policy and is a provider write-off unless you have the limited patient waiver signed, okay? And so use the modifier GA to demonstrate that a waiver is on file. So again, can you bill kinesiotaping? Sure you can. Will it be paid? It depends on the commercial payer policy, and it depends on whether you have coded it correctly and whether you have used the correct modifier. So again, the burden is on the providers and the billers to make sure that you have access to all of these commercial payer policies and are following these policies very carefully. Other things that you're going to find in medical policy are your documentation guidance. Okay, now, and I just took a small snippet of the documentation guidelines for the Blue Cross Blue Shield medical policy for chiropractic services. It's 3 pages long. And so it tells you the documentation guidelines are very clear. So, you know, if you're ever, for example, the subject of a Blue Cross Blue Shield audit, and you want to know whether your documentation is going to measure up, you can go to the medical policy for chiropractic for your state and look up the documentation guidelines. Okay, they're there for you. And it is very, very important that you as a provider are aware of the documentation guidelines for the different payers that you work with. And I will just tell you, they're virtually the same from payer to payer to payer. They follow the Medicare documentation guidelines for the most part. And so, so some of the things that they would state is that having the services you perform sufficiently documented cannot be overemphasized. And so documentation of medical necessity is absolutely paramount. This is just a little excerpt, a tiny excerpt on documentation standards. And, you know, unfortunately, we still have a lot of doctors throughout the United States, chiropractors, who are using travel cards or who are using paper charts for their documentation. And so one of the documentation standards in the Blue Cross Blue Shield Kansas policy states that travel cards alone provide insufficient medical detail to determine medical necessity. That can be very, very problematic, because if you're using travel cards and you're submitting travel cards on a documentation audit, you may have every single one of your claims denied, no matter how well your travel cards are filled out, okay, because it's part of the medical policy. And so make sure that you very, very closely follow the documentation standards provided by your commercial payers and by Medicare. What are some other things that you can look for in commercial payer policies? Number one, how to properly file the claims. So, you know, the commercial payer policies will give you the correct payer ID to use so that you're not filing claims to the wrong payer and having delays in your claims files. How to appeal claims. Now, I'm speaking to the billers here, okay? You know, my billers are very, very well trained on appealing claims, and they know that you can't just, you know, take a claim that wasn't paid and resubmit it and put corrected claim across the top of it and send it through. Nowadays, the payers have very, very specific guidelines on how to correctly appeal claims. Sometimes you have to do it online. Sometimes you have to fax notes. There's all different ways to appeal claims, but it's not the same for every payer. So you can't take a rule of, you know, okay, this is how I appeal claims, or this is how I do a corrected claim, because what works for one payer may not work for another payer, okay? How to electronically submit doctor's notes on request. Nowadays, your provider portals to your payer sites usually have a way for you to electronically upload your doctor's notes. So if they're requesting notes to be submitted with a claim, or after a claim is submitted, you can do that electronically in most cases through your provider portal. Sometimes you can even do it through your software or through your clearinghouse. The other thing you need to look for under your commercial payer policies are the fee schedules, okay? So make sure you obtain copies of your fee schedules and make sure that you are in clear understanding of caps to your fee schedule. So for example, most states, United Healthcare has a per diem cap, meaning it doesn't matter how many, whether you have a 1 modality limit or a 4 modality limit, or if they pay for exams and x-rays at the same visit, they have a cap. I think in Texas it's $60 a day. They're not going to pay more than $60 a day no matter what you do. So you can perform, you know, $55 in services or $155 in services, and the max is going to be up to $60 in payments. And that will include the patient amount. So if the entire amount goes to deductible, there's not going to be any payment. Or if their patient has a, you know, a $50 copay, you may get a $10 payment from United Healthcare and have to get the rest of it from your patient. So be aware of those per diem caps. The other thing is the rules for credentialing and contracting. I find when I take, especially when we take on new clients, that there's sometimes some problems with credentialing within those clients initially, and we have to get those things fixed before claims can get submitted correctly. So remember, there's a big difference between credentialing and contracting. So for example, you might be credentialed as an in-network provider with Blue Cross Blue Shield of Illinois, but that doesn't mean you're contracted with all their lines of business. And what do we mean by lines of business is we mean like you might be contracted with the PPO plan, but not the HMO plan. Or you know, so there are different plans underneath the overarching umbrella that you would need to make sure that you're contracted with if you so choose to be contracted with. The other thing that we're seeing a lot in the chiropractic profession now is that providers are increasingly being placed in tiers. So we're seeing provider tiering, and we are seeing quite a bit of increase in the use of third-party administrators to process and manage specialty claims. And this is what I'm going to finish up with, and then hopefully we'll have about 10 minutes left for some Q&A. So third-party administrators are becoming more and more common in the chiropractic industry. Two of the most common third-party administrators are Optum Health, which was also known as ACN. The Optum Health manages most of the United Healthcare lines of business for in-network United Healthcare Chiropractors, and then ASHN, American Specialty Health Network, which manages many of the Blue Cross Blue Shield and Cigna lines of business throughout the United States. Now, you may be in a state in which you don't, this isn't really a factor for you yet, but they may be coming in. You may be in a state such as Florida or California in which ASHN is completely overridden the lines of business for Blue Cross Blue Shield and Cigna. And so you have to make a decision at that point as to whether you're going to play that game, whether you're going to get involved with these third-party administrators in order for you to be able to file claims in-network with the commercial payers. Third-party administrators are not insurance companies. Be very sure about that. These are contracted entities that perform certain carve-out services on behalf of the insurance company, such as pre-authorizations of services, claims pricing, and pre- and post-claims audits or documentation reviews or peer reviews. And so third-party administrators, again, are not insurance companies. Be aware of that. So let's talk about, I'm going to talk about the Optum relationship and the ASH relationship with chiropractors. And what you're going to need to do is, after this discussion, is sit down with your biller if this isn't already a done deal, or if you're not sure as to which way you should go. Sit down with your biller or schedule a time with me to talk about this and talk about the pros and cons of whether you should be in or out of network with United Healthcare and Optum. So the UHC Optum relationship only applies when the provider is in network with United Healthcare. If you're out of network with United Healthcare, then you don't have to worry about Optum at this point. Now, if you are, and also if you are not a Tier 1 provider with United Healthcare, if you are a Tier 1 provider, then you don't have to go through the Optum pre-authorization of services, go through those hoops. So what happens is, if you're in network with UHC and you're not a Tier 1 provider, there are going to be certain groups that and what I mean by groups is employer groups, in which you may have patients that will require pre-auth of services. And if you look on a patient's UHC card, it's a six-digit number on the patient's insurance card, not their 9-digit subscriber number. So what you would do is, as a provider, it would be highly recommended that as soon as you get the United Healthcare card from the patient, you call this number, the Optum Quick Check number, key in your information, your NPI, tax ID number, key in the 6-digit group code, and it will let you know if Optum pre-auth is necessary or not for that group. If it is, then you can immediately get the patient started on their portion of the patient summary form, which is the PSF 750 form. And again, remember, this is only if you're in network with United Healthcare. From there, you can use the links on the Optum website. So you'll want to have yourself a link to the provider portal, to the Optum Physical Health website, to submit online these disability forms, the back, the neck index forms, and request the correct number of visits that you are wanting, for that patient. So these are this is sort of what you see here on your screen is a snapshot of the Optum website and links to the different clinical forms that you can pick up and use. But again, not all of the groups will require pre-auth. So do the Optum Quick Check, save yourself time. If it doesn't require pre-auth, great. Once you become a Tier 1 provider, and basically you become a Tier 1 provider by kind of playing the game for a while and making sure you're getting your pre-auths in on time and you're following their clinical standards pretty much to the letter based on the clinical policy guidelines that they set forth. If you can do that, they will usually bump you up to a Tier 1 where you don't have to do any of this. And many of our clients are Tier 1 providers They maybe not when they first start with us, but we can get them bumped up to a Tier 1 status so that they don't have to deal with this after, 6 months or a year. Now, be aware with United Healthcare that time is of the essence. Clinical submission forms generally need to be sent in within 10 business days of the first visit or subsequent visits. And remember that United Healthcare has one of the shortest timely filing windows, which is 90 days, and 180 days to appeal claims. If you receive clinical submission denials for failure of clinical submission, you can appeal, but they are very time consuming and they are not guaranteed to work. Some of the instances in which you might be able to get United Healthcare to give you, to like retroactively do these clinical submissions would be in an instance where maybe it's the patient's fault. They gave you the wrong insurance card. And then, 30 days later, you billed out to the old insurance and they're telling you that they're not the carrier. Now you find out it's United Healthcare. It's more than 10 days from the time that you did the clinical submission forms, and now you have to do an appeal. You can usually get those pushed through. Sometimes you can get United Healthcare to do something called a mercy appeal, meaning that you have this big staff turnover, nobody knew what they were doing, and you didn't get any of the clinical submission forms done. And so what you do is you gather all the denials together, send them to United Healthcare all at once, and they they don't guarantee, but they may retroactively get those approvals done so you can get paid. The other thing would be if there are coordination of benefit errors, so you filed the wrong insurance as primary. The provider's tier may also give you more latitude as to what the clinical submission guidelines are, or totally eliminate that requirement. Now, American Specialty Health Network controls commercial lines of business. 90% of California Blue Cross Blue Shield, 80% of Florida Blue Cross Blue Shield, 70% of Ohio Cigna is controlled by American Specialty Health. Now, American Specialty Health is a little bit different because their policies require clinical submission forms regardless of whether you're in or out of network, which is crazy, but it is what it is. Now, if you are so you can say, I am out of network with Cigna, or I am out of network with Florida Blue. That is not going to ameliorate you of the requirement for filing out of network clinical submission forms, or what they call MNR, Medical Necessity Review Forms, to ASH, okay? The big difference is that if you are out of network, you're going to have to submit MNR forms for every visit. If you're in network, or you're in network with ASH, and what that does is that by default puts you in network with the lines of business. So, for example, in Florida, if you are in network with ASH, you're in network with any of the Florida Blue Cross lines of business. Now, for those of you who are listening in Florida, you know that Florida Blue Cross Blue Shield by itself has been a closed panel to chiropractors for years, okay? But you can now get in network with Blue Cross Blue Shield of Florida by going through ASH. And in network, you get 5 visits with no pre-auth, and then after that, you have to start doing the MNR forms. And again, everything can be done online. It's not that hard. It's just that it takes a little bit of management on your end and making sure that you're keeping up with those MNR forms. There also is a little bit of latitude through ASH in retroactively getting some of these clinical submission done. They're not as strict about that 10-day rule. So if you haven't been doing it correctly, you can probably work with your biller to get some of these pushed through. But the bottom line is with ASH, it's not going to matter whether you're in or out of network with a plan. If you are out of network with Cigna or Blue Cross or any plan that uses ASH as a third-party intermediary, then the recommendation would be if you are out of network with that commercial payer, you could put a policy and procedure in place because you're out of network that you are simply not filing claims for those payers, and have the patient sign a waiver to file insurance, because if the patient files themselves, then ASH is going to come back and require you to do those MNR forms, okay? So whether you file or the patient files out of network, those MNR forms are going to have to be done, and it's, and you don't want to have to do that if you're out of network. So out of network, you can make a financial policy that you are simply not filing claims, and that you are going to request that the patient not file claims in order to, and what you can do is, for example, if you go with Chiro Health USA, you can set up a cash fee schedule that is, as an out-of-network plan, many times they have a really high deductible anyway, so you can put them under CHUSA, put them under a nice, or a DMPO, have a cash fee schedule, and say, look, we're just not going to file insurance, we're just going to do cash. Tier 1 providers, again, you do not have to do those MNR clinical submissions through ASH. So if you play the game, there is ways for you to get away from having to do all of this paperwork, but you kind of have to play the game initially in order to make that happen. Okay, so that's pretty much it. Here are some of the takeaways that I would like to see you all look at from today's presentation. Number one, avoid that ICD-10 denial of M79.1. It's causing a lot right now, and I know it's going to get better, but right now it's causing our billers a lot of angst because they're having to spend a lot of time in claims corrections of these M79.1 codes, and just get it fixed. Get it off of your database so that you don't accidentally use it and end up having to have the biller spend a lot of time doing something like that instead of following up on claims that need to be followed up on, okay? Keep an eye out for reimbursement changes on the E&M codes with the commercial payers. Keep track of these evaluation and management and adjustment code pair denials. If you are getting denials from your payers, Blue Cross Blue Shield or other payers, because other payers are beginning to follow suit, and you're getting denials on exams and that are being done the same day as a spinal manipulation, make sure that you're aware that this may or may not be appealable based on the medical policy of that commercial payer. So know when to schedule those exams on a separate day from the CMT. Or if you do, some doctors, what they're doing is they're leaving one of the codes off of the claim and then just submitting for the higher paying code, which I don't like, but some providers are doing that. Keep an eye out for significant reductions in multiple modality services, and if you're seeing that happen, make sure that you look for an updated medical policy to see if your medical policy for your commercial payers has changed. Make sure you obtain a copy of your Medicare LCD. Carefully review utilization and documentation guidelines. Work with your biller to gather up all the commercial payer medical policy guidelines for your specialty and for some of the different codes. So for example, if you do spinal decompression, there are usually separate medical policy guidelines for that. Make sure you know what those policies are so you're avoiding those categorical contractual write-offs because you're not billing it correctly. Billers and providers, make sure you have a direct line in to your different payer and provider portals. Billers, if you're listening to this, make sure you know each payer's policy on submitting claims and appealing improperly paid claims. Don't be spinning your wheels and doing something the wrong way because you didn't do your due diligence in the appeals process. Keep all your portal logins, passwords, and links current in your team folders. Billers and providers, make sure you schedule a meeting to go over any Optum ASH pre-authorization processes to make sure nothing is falling through the cracks if it's applicable to your practice. Providers, if you are thinking about getting involved with Optum or ASH or getting in network with a plan that requires you to be involved, married to that third-party administrator, discuss that with your biller and myself if you want to, the pros and cons. Make sure that your credentialing with the third-party administrator is in order if you want to be in network with any of the lines of business controlled by that third-party administrator. And this one isn't on your note because I forgot to put it there, so I put it in bold. Make sure that you have the correct ABN forms for each commercial payer that requires you to use their forms and not just your generic form that you use as part of your financial policy. Okay, so we've come to the end of the presentation. I want to thank you for your attendance. I'm going to stop the recording because I know things are going to get a little bit loud. And I'm going to unmute everybody. So if you have questions at this time, this would be a really good time to ask any questions that you might have. I'm going to pause the recording now. Thank you all for attending. I'm going to open it up for questions, and if I don't get any questions,